Well, I think there have been a number of studies which have consistently shown that early recurrences of atrial tachyarrhythmia in the initial months following AF ablation are a significant predictor of longer-term recurrence. So certainly there is an association demonstrated there. At the same time, however, there are also data showing that a significant proportion of patients who have early recurrence of arrhythmia following ablation don't develop longer-term recurrences as well. So I think there certainly is relevance to some instances of early recurrence, but it's certainly not a universal feature that all early recurrences mean that the patients had a failure of their ablation procedure. So there are a number of mechanisms which can lead to transient proarrhythmia following an AF ablation. These include a number of different factors, such as development or maturation of the ablation lesions that are delivered. And histological studies have shown that process is complete in around 1 week. Additionally, there is a lot of inflammation caused by AF ablation, so inflammation within the left atrium. And again, that can take some time to resolve. And studies that have looked at biochemical markers of inflammation have shown that these markers tend to spike and then return to baseline after around 1 month. And then finally, another feature that's been recognized is a transient effect on the autonomic nervous system, so autonomic dysfunction, which again, from studies looking at heart rate variability as a surrogate for autonomic function, have shown that this resolves in about 1 month also. Well, as we've discussed, because many of the early recurrences of atrial arrhythmia that occur following an AF ablation are related to transient proarrhythmic factors and therefore don't indicate a longer-term failure of the procedure, it's important to have a blanking period in order to avoid performing unnecessary procedures in patients who won't ultimately need reintervention. I believe the optimal blanking period to be around 1 month. I think there have been a number of studies involving large numbers of patients now that have looked at the time points at which early recurrences occur within that 3-month, the standard 3-month blanking period. And these data indicate that recurrences that occur or continue into the 2nd and 3rd months following ablation are strongly associated or predictive of longer-term recurrence. We ourselves have published data looking at the relationship between the timing of early recurrence and pulmonary vein reconnection, which is of course strongly associated with longer-term failure of AF ablation procedures, and showed that recurrence in the 2nd month after AF ablation is strongly associated with more extensive pulmonary vein reconnection, whereas patients who have early recurrence confined to just the first 4 weeks after ablation, there was no relationship or no association with pulmonary vein reconnection. So based on both this pulmonary vein reconnection data and clinical outcome data, my feeling is that 1 month would be the optimal period.